Good afternoon, everyone, and welcome to our second Social Determinants of Health Rules Advisory Committee in the implementation of CCO 2.0. My name is Ralph Magrish. I will be your facilitator today. Welcome everyone in the room and on the phone. I think we've got quite a large group with us today, anticipating a number of RAC members are on the phone with us as well. I'm going to go through just a little bit of history and context for this project. Those of you that have been with us over the last couple of weeks, you've heard some of this. We will try to keep it brief. We will then move into some housekeeping for the meeting in terms of process, etiquette, and flow, and then we will begin with introductions around the room. So today we will be discussing two specific rules: health-related services and the community health assessment and community health improvement plan rules as part of the implementation of social determinants of health aligned with CCO 2.0. The history and background: this rule rewrite came from recognition of need that the existing CCO rule framework would not be sufficient to support the new rules in implementing the lift in the size and scope of change as it relates to CCO 2.0. To that point, along with substantive changes, we have worked hard to improve readability and align with the CCO contract. We have done so in collaboration with the Oregon Department of Justice, and we appreciate their assistance. Amongst the substantive changes that you will hear from our subject matter experts today, I believe you will also see, if you have looked at or are familiar with previous versions of these rules, you'll note that they've been edited for brevity and clarity. Duplicate content has been removed. We've eliminated a number of outdated terms, and we have ensured that statutory citations are correct. And in some cases, we have renamed rules to improve and clarify the purpose of each rule. We've also moved to a degree to a construct of local and universal definitions to help the individuals using these rules identify the definitions as appropriate to improve readability. Again, we've noted that we are making some of these changes to align with the contract. I will speak to that briefly in the context of some of the things that you may or may not see in rule that you would otherwise expect. Bilateral rights and obligations between the state and CCOs have been defined largely in contract. Third-party rights, and when we speak of third-party rights, we mean first and foremost OHP members and then providers, are generally addressed in administrative rule, which also sets the high-level structure for the Oregon Health Plan. And I would ask anyone on the phone that is not on mute to do so at this time. So we are going to have quite a large group with us today, process-wise, and again, for those of you that have participated over the last couple of weeks, this will be familiar to you. As we go through each rule and introduce each topical area, we will pause and we will ask individuals in the room to raise their hand to get in the queue to speak, offer comment, or ask questions. We will also solicit on the phone seated RAC participants only, just to state their name to get into the queue as well to speak to a specific piece of a rule. We will alternate between room and phone to try to ensure balance and representation and fair opportunity for those that are not with us in person to participate today. We also will host a public comment period. Typically during these meetings, we have taken a break and solicited individuals to do so at that time. I'm not sure that we will take a break today. We will gauge that after we make it through the first HRS rule. If we do not health-related services, I will put $1 in the acronym jar there. Sorry about that. After we get through the health-related services rule, if we are tracking to finish early, I will pause at that time and ask individuals in the back of the room with us, as well as people in the general public participating by phone today, if they would like to offer public comment. That comment period will be limited to 10 minutes regardless of what time the meeting adjourns. If there are 2 people that wish to speak, each will be afforded 5 minutes. If there are 5 people that wish to speak, each will be afforded 2 minutes. Again, that comment period will not exceed 10 minutes. Last piece is about process. I'm going to ask again individuals on the phone to please mute yourself at this time. Thank you. As to process, this RAC, the role of this committee itself is advisory, and consensus is not necessary. The goal and purpose of us being here today is to seek public and stakeholder input to the maximum extent possible prior to us filing these proposed rules. Any individual is welcome to attend. As noted, this is a public meeting. It is being recorded. We are working to get these meetings up on the CCO rulemaking website within 3 to 4 days after the meeting occurs. Those of you that have looked already will note that most of the meetings from last week, those audio recordings have been posted. So what to expect as a RAC member today? My role as the facilitator is to lead the discussion of the rules with proposed changes that are significant or substantive, and to seek your input or feedback on them with the reliance of our subject matter experts to provide full context. How to provide your input and comments in addition to the opportunities that you will have today. This is very important. You will have 7 calendar days after today to provide additional feedback or comment to us in writing. That is for seated RAC members only. Those comments will need to be received to us by close of business next Thursday, 5 p.m. If you would be so kind to help us out in that subject line, if you will please put your organization's name and SDOH RAC number 2, so that we can identify that. As you'll understand, we've done about 13 of these in the last 12 or 13 days, so we want to make sure that as you're taking the time and effort to submit meaningful comments to us, that we get them and that we capture them accordingly. So we appreciate that. I'd like to speak more broadly now to the general public who's with us in the room and on the phone about public opportunity to provide input or comment. That will come on or about November 1st. What will happen during the month of September into October is the agency will take, synthesize, and process all of the feedback that we have received from all of the rules advisory committees this month to review and make determinations if those recommendations will be accepted into the final proposed rules. That final set of proposed changes will be posted through the Secretary of State and the Oregon Bulletin on November 1st to start the official public comment period, which will run through November 18th. There will be a public hearing in this building on November 15th, exact time and room, although anticipate this room. It will be in this room, thank you. Will be provided on our website as well for individuals that wish to attend that public hearing as a matter of process as well. And lastly, these rules will take effect on January 1st, the effective date of the new contracting cycle. So that's it as housekeeping and process. We will begin with introductions in the room to my right. After we make it around the table, Kim Stubenrau, who is with us, will take roll of RAC members on the phone. I am going to stress the importance to RAC members on the phone to mute your phones if you are not speaking or participating. Do not, I repeat, do not put us on hold. If you do, and your organization or entity has a music system, the rest of us will have to listen to it. And we have noted throughout the last week's discussion that it can be very disruptive. So we implore upon you, do not do that. If you are participating in listen-only mode as a matter of the general public, we ask you to mute your phone as well. So we will begin with introductions to my right.
Tom Wonderborough, Medicaid Policy Analyst, OHA.
Hi, I'm Sarah Boudreau. I work in the OHA Office of the State Public Health Director. Hi, Anona Gund, Transformation Analyst with the OHA Transformation Center.
And also need to interrupt, and apologies, should have stated this, we are going to ask everyone to use microphones, OHA staff as well, to ensure that folks in the room and on the phone can hear. Thank you.
Lori Kelly, Manager of the Social Determinants of Health Office.
We didn't get any of that.
Sorry about that. Lori Kelly, Social Determinants of Health Manager in the Health Systems Division of OHA.
Sean Steiger, Application Assistant for Project Access Now.
Kristen Brunston, Director of Strategic Initiatives, Health Share Oregon.
And Kristen, if you could hold on one second. I do need to ask all people participating by phone to please make sure your phones are muted at this time. Whomever it is that is, I don't know if you have in a car or window down or anything else, but it is causing a significant disruption in the room and for others wishing to hear. Thank you. Kristen, please again, I'm sorry.
Christine Brunston, Director of Strategic Initiatives, Health Share Oregon.
Andrea, Program Coordinator, Health Programs Coordinator at the Ties of Change in Tillamook, Oregon, and Region 1 rep from the Oregon Coalition Against Domestic and Sexual Violence.
Colin Sanders, Benefits Navigator at at Cascades Project.
Jen Howe from Eastern Oregon CCO. Lisa Rose Gagnon from Disability Rights Oregon.
Red is on.
Red is on.
Red is on.
Lucy Zamorelli with Trillium. Marianne Blankenship with Pacific Source. Lakeisha Dumas, Traditional Health Workers Commission Chair.
Kristen Downey, Providence. Red is good.
Red not on. I'm Glenn Kierson with Advocate from Clackamas County.
Melissa Hanks, Deputy Project Director for CCO 2.0. Jenna Zion Hall, Oregon Health Authority.
Kim Stubenrad, Oregon Health Authority. I'm going to go down the list as I have it. If you are in attendance on the phone or in the room, if I missed marking you down, please let me know. Carolyn Anderson.
This is Tom Sensick from Healthcare for All Oregon.
Thank you, Tom.
Lorene O'Brien, Community Advocate.
Actually, if you'll sit tight, we're going to take an actual roll rather than have folks state their names. So when you do hear your name, please acknowledge your presence. Thank you.
Joelle Archibald.
Here.
Rachel Banks.
I'm here and I'll be joining you all shortly.
Beth Englander.
Here.
Susan Bolt.
Here.
Bill Bushka.
Here, thanks.
We know you're not here. Brandon Cruz.
Here.
John Curtis.
Here.
Tony Erickson.
Present.
Nicole Fields. Sarah Franklin. Morgan Fuco. Alicia Godinez. I'm sorry, Angelica.
Here.
Thank you. Renee Hancock. Jenna Harms. Jarrett Hefner.
Emily Johnson for Jenna Harms here.
Thank you, Emily.
Jarrett Hefner. Carly Hood Ronick. Aaron Jolly.
Here.
Zena Jimkier. Xenia, sorry. Lynn Knox. Kimberly Coops.
Here.
Miriam McDonald. Katrina McPherson.
Here.
Cammie Miller. Ned Mossman. Amanda Normeen.
Here.
Nancy Rickenbaugh. And I saw Jeremiah come in, so. Lindsay Staling. Laurel Swerdlow.
I'm here.
Liz Thorne. Carrie
I'm here. Hi.
Okay. Carrie Trapp.
Carrie is here.
Robin Traver.
Present.
Don Wallace.
All right.
Thank you, everyone.
Thank you for that. So everyone, before we begin, I'm going to note that we have literally half of this advisory committee, I think 19 members participating by phone today. So I'm going to ask for everyone's patience and cooperation so that we ensure everyone has equal opportunity to participate. Again, we'll go back and forth between phone and in the room. Folks on the phone, when we do solicit your names to speak, we will ask you to state your name one at a time and just do our best to, again, put ourselves in the queue. It will not be an invitation to speak directly. We will put you in the queue and then acknowledge your name at that time to begin. So the first rule that will be open for discussion.
Excuse me.
Yes.
Excuse me. This is Jesse Beeson. I think I'm a RAC member. At least I was last time, and I did not hear my name.
Jesse, what organization are you with? I'm sorry.
Northwest Health Foundation.
All right.
And then this is Stick Crosby. I didn't hear my name called either with All Care.
All right. And Stick, we did have you captured in Josh's place. And Jesse, just to be clear that you are with Northwest Health Foundation, all right, we thank you and we welcome you. And with that said, we now have more than 50.
Well, also Sandy Sampson, I was on the first RAC, but not mentioned either, so.
All right, we welcome you, Sandy. To that point, we have better than half of this group on the phone, so I'm going to ask for everyone's patience and cooperation as we work together to run an efficient meeting here. With that said, we are going to have our first rule open for discussion, which is 410-141, 3845, health-related services. I want to welcome Tom Wonderbrough, our waiver manager and policy analyst, to provide context for the changes to this rule.
I'll be speaking to sections 1 and 2 of this rule first, and we'll pause at the end of section 2 for any comments. Section 1 states the goal and intent of HRS, and the changes here were rewording for clarity, no major changes. Section 2 defines requirements for HRS. The changes we made here were to create consistency with federal rule. We did remove a list of service types because that list was not exhaustive and OHA did not wish to be prescriptive. These sections are Section A lists the acceptable types of design for HRS, Section B lists acceptable goals for HRS spending, and Section C lists exclusions. I'll pause there at the end of Section 2 for any questions.
If we may see just by show of hands in the room first, anyone wishing to ask, again, specific to items 1 and 2. All right, I see one hand in the room. Sit tight, please, Tom.
We're on health-related services, I'm assuming.
Yes.
Okay.
Yep, sit tight. By name only, RAC participants on the phone, if you wish to speak to these two pieces, please state your name at this time.
Beth from
Lorene O'Brien.
I got Beth and I got Lorene O'Brien. Anyone else? Okay, we are going to start in the room. I think first recognizing, and apologies, first we'll go to Tom Sinzak and then Christine from HealthShare. Tom, please, if you'll use the microphone. After these two individuals, we'll first go to Beth and then Lorene, and then we'll do another round and go to Marion Blankenship in the room after the two individuals on the phone. Tom, go ahead.
Tom Sinzak with Healthcare for All Oregon. Just one brief commentary in number 1, how to define efficient in a completely inefficient healthcare system is a very important thing to consider. Something requiring efficiency in a system that doesn't have that. In particular, it used the word resources, and I would think maybe that could be better defined. The last part of number 1, before A, health services are provided as a supplement. When we're trying to look at social determinants of health, we need to get rid of this word supplement. This has got to be a necessary part of upstream work. So I'd say health-related services are a necessary part of the overall work that needs to be done by CCOs as an amendment to that line. A necessary part, not a supplemental part.
So I want to make sure I understand if there are questions in there or comments. Was there a request to reword?
Yes, a request for a reword, number 1, at the end. The first part was a comment, but then health-related services are a necessary part of overall health services.
All right, thank you for that comment.
Healthcare services, yeah.
Thank you, Tom.
Okay, and then I have 2 more comments. An A, HRS need to provide flexible services basically it says may be provided, need to provide. However the grammar on that works out. In B, HCAs need to have flexibility and provide necessary health-related services. So that's the wording in there as well. In C, and I'll end up with number 1, and then if I want to go back to 2 later. Complete discretion for CCOs, that's my commentary. Wow, there needs to be requirements. This is a setup for disparity in an unequal process system across CCOs, since every CCO has their own complete discretion. I think that's dangerous words, so thanks. I'll go to 2. I have comments on 2 as well, but I'll wait.
All right. Thank you for your comments. We'll recognize Christine Bernstein from Health Share of Oregon.
I had comments about part 2, subsection B, talking about measurement and outcomes. Measuring improved outcomes related to social determinants of health intervention in a short period of time is very challenging, and if it's a 1-year period, probably impossible. And so really thinking about what we're trying to demonstrate, the impacts of those interventions are really seen over the long term. For the section D, the criteria which investments are based on, that criteria listed in subsection D would limit health-related service interventions to clinical interventions, which is the opposite of what I think they're intended to be. And additionally, the language around evidence-based medicine interventions reinforce dominant culture and don't leave space for community-based solutions to come up. Thank you.
Thank you. We will go to Beth Englander on the phone and then Laureen after that. Beth, go ahead.
Okay, thank you, Ralph. All right, in subsection 1 of this rule, I think I'd like to request that there be a definition of flexible services put in, unless I'm missing it, and it is somewhere. It didn't look like it was in a general definition section. It is distinct from the larger definition of health-related services, so I think a separate definition is necessary. Again, please correct me if I've missed it, and it is in the rules.
So, Beth, if I can, the definition of flexible services is found in number 4 in this rule, but certainly if you wish to make comment that it should be placed more prominently, we would happily accept that as well. Or
got it. I see that. Maybe just refer to as described in subsection 4 would probably be helpful.
Thank you. Anything else? Go ahead.
My second comment on section 1 echoes a previous speaker's. I do not see any directive by the agency in this rule that all MCEs or CCOs must provide some HRS. Everything seems permissive, and in 1 sub A it does say health-related services may be provided. I don't see anywhere else in the rule where it says they are required to be provided, at least to some extent. Again, caveat, I may be missing it, but if that isn't in there, I'm requesting that it be explicit that CCOs are required to provide some. And let's see, in 2 sub C, 2 sub little a sub big C, there is a requirement that, it looks like the agency is requiring that if health-related services are provided, they're directed toward either individuals or segments or entire populations. We'd like to request that they be directed towards all of those populations. The way it's written right now, it looks like health-related services could be, if they were provided at all by a CCO, could be provided exclusively on a public, community-wide basis, and so individual flexible services might be completely not available to people assigned to a particular CCO, while they might be available to other people in another CCO, and we think that is problematic.
I heard 2 questions there that I can speak to. The second one in part 2, that's a repetition of a federal rule. The OHA does not have the authority to change that federal definition. We're repeating it here in rule. The first question.
I'm sorry, I can't quite hear you. Which one were you referring to?
The second question you had in big C under little a under section 2. be directed towards either individuals or segments. All of Section 2 is a federal rule. That's not an Oregon rule. Federal statutes about health-related services apply, and we've repeated them here in the rule. So we are not at liberty to, nor do we have the authority to change those definitions. The first question about requiring CCOs to spend on health-related services is prohibited by OHA's waiver with CMS. In our waiver, it states that OHA can only require managed care entities to pay for covered services, and health-related services are non-covered services. Therefore, there is no minimum requirement from the OHA to CCOs to spend on HRS.
Well, I just respectfully would point out that the 1115 waiver indicates that health-related services would be at least considered by all CCOs, and that they have to be at least considered. And I'm not sure that comes through clearly in this rule. And in addition, I am looking at the federal rule that you're basing subsection 2 on. And although it does define health-related services broadly, it's not clear to me that it requires that limitation that health-related services be provided to potentially to only one of those three categories you have in 2 sub A sub big C. In CFR 45-158-150.
So Beth, we can look in, we've captured that comment and feedback, and we can do that review of the CFR itself and respond accordingly.
Great, thanks.
Sure. I'm going to recognize Laureen O'Brien from the general public on the phone, and then we'll go to Marion Blankenship from Pacific Source in the room. Yes. Okay, Laureen, go ahead.
Great. Thank you. Number E, under number 2, the support expenditures related to health IT and meaningful use. I wasn't sure what support expenditures meant. If it only covers the support of HIT, or if it actually covers the network, the hardware, the software, if there is a community information exchange. So my one point was I just wanted clarity, or maybe that could be better worded, what is included, or what the CCOs can spend on health IT related issues related to a community a network, and then because it's not explicit, and then if there's going to be similar to the other requirement, there doesn't seem to be any requirement to participate if there is a community information exchange. So those are my 2 points.
Thank you for those. So again, the wording, the language used there in section 2 is pulled directly from the federal rules. OHA is not seeking to add any language in these rules to the federal language. If there is a request for additional guidance to specify in other documents, we will certainly consider that, but that won't be done in this rule, I believe.
Okay.
All right. Thank you, though. We appreciate that. Can I just check in on the phone real quick, name only, if there are other individuals that wish to speak to these first 2 sections? May I see by show of hands in the room anyone else?
Sandy Sampson on the phone.
Okay. Sandy, let's have you, and then we'll go to Jeremiah Rigsby in the room. Section 3. Okay. Sandy, you've got the floor. Go ahead.
So when we're talking on section 2, which it seems like it's pretty loose, who's speaking on behalf of the definitions of 42 CFR 158-150?
So this is Tom Wonderbrook.
At your end.
Could you repeat the question?
I just want to know who you are that is explaining regarding the CFRs.
Tom Wonderbrook, Medicaid
and the
policy
CMS billing.
Sure. So, Tom, if I can introduce Tom as one of our managed care policy analysts and also our 1115 waiver manager.
Thank you.
Okay, Tom who?
Wonderbrook.
W-U-N-D-E-R-B-R-O.
All right. Thank you, Sandy. Appreciate. Did I see Tom? Okay. We'll recognize.
First of all, I'm strongly supporting what Christine said and what the person on the phone said. And in terms of...
And Tom, can I ask you to use the microphone so we can make sure everyone on the phone? Thank you.
This is Tom.
Tom Sensick, Healthcare for All Oregon. I'm strongly supporting what Christine said and the person on the phone said. and trying to find out, I'm hearing from some very strong language here, this is how it is, and there's nothing we're going to do about it. And that's concerning in a advisory committee where listening is essential. And so the idea is, I'm going to ask a question, is this absolutely restrictive language, or can it be added to?
So they're kind of, the federal rules are not something that the Oregon Health Authority is able to change. So it could be added to at the federal level, but it's not something that our agency has the power to do.
We can add extra elements that as long as we don't contradict.
I think, Tom, that's the question is, are the federal requirements the floor or the ceiling?
Right. That's the great question, and that's what we should look at that. And of course, we have to do some federal work, we'll do it. Okay, so in particular, understanding that as interpreted now, no changes can be made to this section 2. I'm wondering why questions were asked about that. But I will go ahead and just say that the comments were important. And I want to make one recommendation that has to do with 2B, let's see, 2 small b, E, I think I got it right, support expenditures related to health information technology. And there's the later section that talks all about school-based services and all that stuff. So I'm just going to make a comment as this technology should be dumped into school nurses. This is going to be the best use of money that can possibly be made. They were completely out of the technological loop. I served on the school nurses task force that was governor appointed and was a great meeting. There were a lot of recommendations, and the school nurses need to get into the tech world so they can be a part of integrated and working on these issues. That's my comment. Thank you.
Thank you. I'm going to invite Tom to move us along with the rest of this rule.
So give a summary of sections 3 and 4 and pause at the end of section 4 for questions there. Section 3 lists the requirements for CCO's policies and procedures related to health-related services. The changes here were to refine requirements for HRS policies so that they'll work better for CCOs and OHA. Section A states expectations for transparency and accountability. Section B speaks to alignment of community benefit initiatives. OHA welcomes opportunity to clarify language there. Section C ensures policies describe the role of the CAC and tribes. And Section D states that policies shall not limit the range of HRS services. Section 4 describes documentation required for flexible services. There's no big changes to the wording here. Most of this language just moved from one part of the rule to another part. Section A explains that, well, I won't read through those sections explicitly. Most of this wording just moved from one part of the rule to another part in Section 4. I'll pause there at the end of Section 4 for questions on Sections 3 and 4.
And may I see by show of hands individuals in the room? I'm seeing Jeremiah, I'm seeing Jen Howell from EOCCO, I'm seeing Tom. Do I see any other hands in the room? May I ask first any individual on the phone? I'm not sure what we are hearing, some beeping. It may be another individual receiving an inbound call perhaps and their call waiting, but or putting us on hold. Please do not do that. May I solicit names at this time, names only of seated RAC members that wish to get in the queue to speak to items 3 and 4.
Stick.
I'm sorry?
Beth.
Who was it before Beth? I'm sorry?
Stick.
Stick?
Stick Crosby.
Thank you, Stick. And then Beth. And I'm going to remind folks and ask apologies to make sure that you do state the name of your organization that you are speaking on behalf of. After Stick and Beth, were there other individuals on the phone that wish to get in the queue?
Bill Borsko with IHN.
All right. Anyone else? All right. We are going to go in the following order. Jeremiah Rigsby from CARE Oregon, Jen Howell from EOCCO, Tom Sinzik from Healthcare for All Oregon, Stick Crosby, Beth Englander from the Oregon Law Center, and Bill Buska from IHN Samaritan. We welcome Jeremiah Rigsby from CARE Oregon.
Thanks. Yeah, Jeremiah Rigsby. So 2 quick questions in 3. With 3A, I think we got a good idea of the intent here, but wanted to see if there's any clarification on the term unnecessary barriers. I think that just means, don't be a jerk instead of obstacles. This is the closest we can get to in statute putting that in, but is there any particular definition that you guys are looking to?
I don't have one at this time, but I will take that.
Okay.
Thanks.
The second thing is, just practically speaking, and this is more of a comment, the goal in 3A is to reflect streamlined administrative processes. You might think about hearing what that means. So to quickly get something like a $1.25 bus pass to somebody, the reporting and rigor for that versus getting like a $400 air conditioning unit maybe should be a bit different as far as efficiency goes for reporting. So just a comment there. Second thing, in 3C, the policies and procedures shall describe how HRS spending decisions are made, including the role of the CAC and tribes in spending decisions. It might make sense just to clarify that makes probably a lot more sense for community benefit initiatives, but not for more individualized flexible services spending. Just a comment there. Thank you.
Thank you, Jeremiah. We will recognize Jen Howell from EOCCO.
Hello, Jen from EOCCO. I just have two questions about this section. Section 4 talks about flexible services, and then at the end, the last sentence talks about determining the HRS needed to supplement the member's care. These services shall be documented in the member's treatment plan and clinical record. And I just want to clarify whether the intent is to include all health-related services or just flexible services, because sorry, I forgot his name, kind of mentioned, it's pretty burdensome to ensure that community benefit initiatives get into treatment plans and medical records. So I just want to clarify what the intent was.
Yes, thanks. So the intent there was to limit that to flexible services and not to have community benefit initiatives in individuals' records.
All right.
Okay, sorry. One more question. I'm sorry.
No problem.
Thank you for clarifying that. My second question relates to the appeal or hearing rights that are referenced in number 7. It says that except as provided in section 4, which appears to me to provide grievance rights, but I don't see anything that would authorize appeal or hearing rights. So I just wanted to ask for either clarification that there is something that I am missing, or see if we can somehow reword number 7 so that it doesn't look like there are appealing hearing rights if there are not.
So I hear that request for clarification on 7. 7 refers back to section 4, both A and B, and so part B of section 4 does state how a written notice could inform a member and the provider of the member's right to file a grievance in response to the outcome. So that was 4B.
Sorry. Thank you for the clarification. I just wanted to make sure that I'm not missing. I am not an expert on appeals and grievances, but I thought that an appeal and a hearing was different than, like, that whole process are kind of simultaneous and separate.
So yeah, I hear the request to clarify that language there. We'll make sure that the language in 7 and 4A and 4B line up on all of those things.
I really appreciate it. Thank you.
All right. Thank you, Jen. Before going to Tom in the room, I am going to ask all RAC members on the phone, please stay, if you are in the queue to speak or otherwise, please stay on mute until you are asked to speak otherwise. We will all be better for it in our ability to hear one another and have better flow of communication. With that said, Tom Sinzek, Healthcare for All Oregon.
Tom Sinzek, Healthcare for All Oregon. I got potential edits on 3 areas and 4. Under 4, the intro, based on previous conversations in this room, consistent with the member's treatment plan and is developed by a culturally responsive member care team. That is, people don't know how to work with people, then this is going to fail. So, and there's other references in the previous, discussion of social determinants related to that. Next one is, and maybe this is a part that's restricted, that is, this cannot be, refusal cannot be considered an adverse benefit determination. Is that by federal law?
I believe that that's in our waiver, but I'm not sure. We can get back to you to tell.
Okay, well, I would say that basically a refusal to a permit should be considered a adverse benefit determination, because it could certainly impact significantly a person's health. And so that would be my language. And then the last one is under B. I would say, upon written notification, well, that's the whole thing. Inform the member and provider of the member's right to file a grievance, the right to file a grievance. It's extremely challenging for me as a professional to grieve issues. And I don't know how you expect a basic person to, just respond. So I'm going to add something like, in response to the outcome, and shall be offered assistance in filing that grievance.
And Tom, hold on just a sec. I need to implore upon all individuals participating by phone to mute their phones or to not put their phone on their desk or use their keyboard. I will stress that the nuclear option that we do not want to exercise would be to mute everyone on the phone so that the meeting could continue in the public setting here. We do not want to do that. We absolutely do not want to. So please, I implore upon you to put your phones on mute or to maintain or control any ambient noises that you may be creating that are impeding our meeting. Thank you. Tom, did you wish to continue?
No, that was my last comment.
Okay. I'm going to recognize Stick Crosby from All Care on the phone, then Beth Englander from the Oregon Law Center, and then Bill Bushka from IHN Samaritan, in that order. Stick, go ahead.
So my comments related to kind of 3A and 3. I'd just really like to see something that calls out when the state's reviewing these policies and procedures that there's a standardized reporting process. When you have two CCOs in an area, it can make it difficult for some of these organizations to be doing different reporting. So as long as there's a way that that standard is reflected there, I don't know if it's best in this language or OHA policy. And then 3C, I do want to argue that I think this should stay with the role of the CAC and the tribes and the decisions because it creates that local accountability in the policy and the process, and I think that that's important there. And that's all I have to say.
Thank you, Stick. We appreciate. Beth Englander from the Oregon Law Center.
Thanks. This is Beth from OLC. Let's see. I'll start commenting on 3A. Oregon Law Center is requesting that the language in sub A be changed. Instead of using the word encourage transparency, we're requesting that transparency be required in the health-related services policies and practices. The encouraging transparency is it's simply not enough in this context. We've got billions of dollars of Medicaid money being spent in ways that sometimes it's hard to identify how it's being spent, and that level of transparency is really critical to a number of ways in which the healthcare transformation is supposed to work. So we're asking that it be required, not encouraged. And I also think that's really the word require instead of encourage would be more consistent with both the agency and the legislative intent of how these benefits should be provided. Additionally, the sub C, the policies and practices shall describe how the decisions are made, and I'd like to echo the last speaker's point that there really needs to be consistency in how the HRS spending decisions are reported on, both in how they're made and what they were spent on. So I guess that triggers sort of one of the subsections in 4. Members, OHP enrollees need to be able to decide, especially if they have a choice, which CCO they would like to go to, and the agency itself needs to be able to accurately and fairly evaluate how different CCOs are doing in providing health-related services. And without consistency of reporting and transparency in reporting, that's really difficult. Also in 3 sub little d, I am reading that section to say that, in fact, CCOs do have to at least consider any request for either individualized flexible services or the more community-oriented benefit health-related services. Am I reading that correctly?
I think what D there is trying to do is to ensure that the policies themselves don't limit that range, rather than to state that certain actions have to be taken by the CCO when they receive requests. But if that's a request to clarify there, we can clarify that.
Yeah, I think, because I personally am not clear about what it means, especially the end of the sentence, other than by enforcing the limits defined in this rule. So doesn't come across clearly to me, and it may lead to discrepancies in how HRSs are provided. So in subsection 4, this will come as no surprise to most of you, but Oregon Law Center and Legal Aid Services of Oregon have really, really grave and profound concerns that the health-related services and flexible services that are being provided and being paid for by federal and state Medicaid dollars are taken out of the due process requirements that are clearly attached to Medicaid money. So we're requesting that the sections that say that people only have the right for a grievance be changed and have the health-related request for health-related services, at least individualized requests for health-related services, or include all of the, and if those requests are denied, or if benefits are reduced or terminated, that they be given the same level of due process in terms of notice and opportunity for a hearing as any other Medicaid denial, reduction, or termination of services.
Beth, sit tight one moment. I'm going to ask whomever's ambient noise we can hear, please put yourself back on mute. Thank you. Beth, go ahead.
So I think that's it for my comments up to that point.
So we hear and acknowledge the request to strengthen the language around the grievance process for HRS that's described in Section 4.
All right, I'm going to go to Bill Buska from IHN Samaritan, then I will do one more pass in the room by show of hands and one more check-in on the phone, and then we will go to the rest of this rule. Bill, go ahead.
Thank you, Ralph. I am on Section 3C, and I think it's similar to what Jeremiah and a couple others have commented about, but about the role of the CAC in tribes in spending decisions. Describing their role in flexible spending decisions is really difficult because those are individually based and part of the plan of care and what goes on with the individual. So I would request that be clear that it's around the community benefit spending and community benefit initiatives, which is much clearer role for the CAC than for individuals. And there are two other sections of the rule where that makes it more clear. In 141.37.35, 6A, it makes it clear that it's about community benefit. And then below in 5A, it also is just about community benefit. So just asking for some consistency in the rules. Thank you.
Thank you. Can I just check by show of hands in the room, is there anyone else that wishes to speak to these? May I hear by name only anyone else on the phone that wishes to engage on this?
Robin Traver.
All right, we're going to go to Robin Traver on the phone. We're going to go to Lisa from Disability Rights. We will go to Tom Sinzik, and then we will close on these, and Tom Wonderbow will introduce the remainder of this rule. So, yeah. And Robin will get to you after the two individuals in the room. I'm sorry. Go ahead.
Lisa Rose, Disability Rights Oregon. I'm just seconding the concerns about due process rights.
Thank you. Tom, go ahead.
And I'm going to save my comments from 7, which is about a 4. And the same thing. There needs to be a right to appeal. And whatever that is in 4, then 7 could stand as it is. So I want to comment on that.
All right. Thank you, Tom. We're going to go to Robin Traver for last word on these before Tom closes out with 6 and 7. Robin, go ahead.
Okay, so back up to 3. Regarding OHA review of the policies and procedures, would like to request that review, that process and that due date be put on the CCO contract deliverable matrix, and that there is a standardized process from the OHAs, and so that there's timely review of these policies and procedures.
Thank you. All right. I'm going to welcome Tom Wonderbow to provide the overview of the rest of the rule, and I think I said 6 and 7, but I think I meant 5, 6, and 7. So Tom, go ahead.
Thanks. Section 5 describes community benefit initiatives. Part A states that CCOs shall designate a role in the CAC in tracking and reviewing community benefit initiatives. Part B states a documentation requirement through the TQS report. This is legacy language that will be removed from rule going forward. That's what exists in rule now. We intend to strike that going forward. Exhibit L is the only required reporting mechanism for HRS spending. Section 6 restates reporting requirements, and there are no changes to that rule. We just moved where it is. And Section 7 excludes appeal and hearing rights. Again, no changes to that as it exists in current statute.
And by show of hands in the room first, anyone wishing to ask question or offer comment? Seeing none seeing one actually rather, before we go to Marion from Pacific Source, can I just get name only of individuals on the phone wishing to speak or offer comment on numbers 5, 6, or 7 through this rule, and this will be last call for this rule.
Sandy Sampson.
And thank you, Sandy. Anyone else? Beth. Sandy and then Beth. And anyone after Beth? Okay, we will go in the following order. Marion Blankenship from Pacific Source, Sandy from Yellowhawk Tribe, and then Beth from OLC, and then back to the room to Lakeisha Dumas, and that will close out this discussion. Lakeisha reserves right to speak after if she wants to. We'll put a placeholder there. Marion, go ahead.
Okay, thank you. We have a comment in regard to 5 small a. CCO shall designate a role for the Community Advisory Council in directing, tracking, and reviewing community benefit initiatives. And I think our concern here is that this once again begins to blur the boundaries between the CAC and the governance board. I think our perspective is that it's not really the intent or focus of the CAC to provide managerial oversight, so to direct and to track, and would recommend that the language be revised to say advise and review, or advising and reviewing, just to maintain some clarity between the CAC and the board. Thanks.
And thank you, Marion. Before we go to Sandy and then Beth, I will state, it's remiss if I did not previously, that when individuals do submit their written comments during the course of the next 7 calendar days, and that by all means includes the invitation for you to submit proposed language in there as well. So we want to make sure that you have that opportunity and that is a clear understanding to you. Let's go to Sandy from Yellowhawk and then Beth from the Oregon Law Center.
Yeah, this is in regard to 6, and it says the CCO shall submit their financial reporting for health-related services. So is there any state performance test measures that maybe the OHA is accountable to CMS, kind of like when they did the incentive measures for financial incentives for CCOs? This is to Tom.
Yes, so generally OHA has a lot of requirements back to CMS. Most of them are stated in our 1115 waiver.
All right, thank you.
So there is some in regards to health-related services. You were just saying that it wasn't a requirement through CMS through the current regulations. So I'm just trying to get clarification. Is there, and where do I go to look in the 1115 waiver in regards to health-related services? Was it a state plan amendment, or was it in the 1115 waiver when it was introduced?
In the approved 1115 waiver, special terms and conditions 36 contains the provisions on health-related services.
Thank you.
All right, let's go to Beth Englander for the last individual to offer a comment or question on the health-related services rule. Go ahead, Beth.
Thanks. This is Beth from Oregon Law Center. Just in relation to the sub 5 in the rule, the explanation of community benefit initiatives kind of highlights concern I raised earlier, that in general these health-related services rules appear to allow a CCO to provide, for example, nothing but a community-level intervention as the totality of the health-related services that they're going to provide, if they provide any. And I really want to emphasize that I think this, it could be that in one CCO, the only thing available for anyone who's enrolled in that CCO is like a community-wide diet and nutrition class that's offered, whereas in another CCO, people can get help, paying rent if they are short $50 in a month, and eviction is going to destabilize their health, and that it just could lead to very, very disparate impact of health-related services throughout the state, and I'm concerned about that. And I think we're asking that there be some determination that some of each sort of health-related services be required to be provided within each CCO. In addition to that, I'll just, in regard to sub 7, I'll just repeat my concerns that without assigning due process rights, including the right to a notice and the right to an appeal, a denial or reduction or termination of a flexible service or health-related service directed to an individual, and any MCE or CCO or the health authority is leaving itself open to liability for violating federal Medicaid law, and I really encourage the agency to change that.
Thank you. All right, thank you, Beth. We will absolutely take that under advisement. The time is just about 5 to 2, unless there is an overwhelming majority of individuals in the room that wishes to take a break, which I would ask them to raise their hands at this time if they feel strongly about taking a 10-minute break. I am seeing no hands go up, so we are going to forge on. Before doing so, I'd like to just take a quick pause and solicit public comment from members of the general public on the phone. Is there anyone at this time from the general public on the phone that will wish to sign up for public comment at the conclusion of our next rule review? Please state your name at this time.
Megan Dorton, Legal Aid Services of Oregon.
Thank you, Megan. Anyone else? Anyone else on the phone wish to sign up for public comment? May I ask individuals in the back of the room if anyone, just by show of hand, would wish to offer public comment? All right, seeing none, we will continue. I'd like to introduce Sarah Boudreau from the Public Health Division at the Oregon Health Authority, and Anona Gunn from, Lakeisha, my sincere apologies. We got one more here on health-related services before we close out. Thank you.
Lakeisha, just a quick question on 5, clarity on which one was going to be stricken from that?
Thank you. The part that's in there now is 5B, that states community benefit initiatives will be reported through the CCO's transformation and quality strategy update and annual reports. That's a way that we used to use reporting in the past. We're going to switch off of that and stop using that for health-related services. So going forward, health-related services will only be reported through Exhibit L.
And second question, clarity on the intent for the role of the CAC. Is it more advising or more directive? Like having a more robust?
I appreciate the question, and I don't have a response now, but I do appreciate the request for clarity on what that role is for the CAC. Thank you.
All right, thank you, Lakeisha, and again, my sincere apologies. All right, at this time, we are going to move to OAR 410-141-3730, Community Health Assessments and Community Health Improvement Plans. I want to welcome Sarah Boudreau again from the Public Health Division and Anona Gunn from our Health Policy and Analytics Division. Go ahead.
Great, thank you. So we'll shift gears and review rule related to CCO Community Health Assessments and Community Health Improvement Plans, also referred to as CHAWS and CHIPS. These rule changes implement policy numbers 8 and 9 from the Oregon Health Policy Board. Really? From the Oregon Health Policy Board CCO report from last fall. So I'm going to go ahead and read those two policies. Policy number 8 reads, requires CCOs to partner with local public health authorities, nonprofit hospitals, and any CCO that shares a portion of its service area to develop shared CHAWS and shared CHIP priorities and strategies. Require that CHIPs address at least 2 state health improvement plan priorities based on local need. If a federally recognized tribe in a service area is developing a CHA or CHIP, the CCO must partner with the tribe in developing the shared CHA and shared CHIP priorities and strategies described above. And ensure that CCOs include tribes and organizations that address the social determinants of health and health equity in the development of the CHA-CHIP, including traditional health workers affiliated with organizations listed in statute. So that's policy number 8 that drives this section of rule, and policy number 9 reads, requires CCOs to submit their community health assessment to OHA. The goals of these policies are to improve population health outcomes through CHA and CHIP collaboration and investment. Ensure CHAs and CHIPs reflect the needs and priorities of the entire community and reduce burden for community members and stakeholders by having shared assessment and planning processes. Finally, they increase transparency and support of community partner efforts. So we'll read sections of the rule language directly and then provide background and context and then take your questions. We will jump around the rules sections a bit for CHAs and CHIPs, which allows us to group similar CHA sections with similar CHIP sections. So this is the order that we're going to read through the rule sections with changes. So we'll go in the order of section 1. Sections 2, 7, 8 will be grouped. Sections 3 and 9 will be grouped. And then we'll proceed with section 4, 5, 6, and 11.
Thank you. And we'll say very clearly what we are reading in the moment to make sure we can all stay together. And if you get lost, let us know, because sometimes I get lost in these. All right, so overall, there's been actually quite a bit of reorganization of this rule, and that was really intended to split apart the requirements and for better clarity for the CHA versus the CHIP. So community health assessment versus community health improvement plan, just to make it easier to digest and understand what is there. So I'm going to start with section 1. I'm going to read some language and then give you some context and then pause for comments and questions. So section 1, so CCOs shall comply with the requirements in the stated statutes as well as any requirements specified in the contract regarding the community health assessment and community health improvement plan, the CHA and the CHIP. To the extent a CCO shares all or part of a service area, the CCO must develop a shared CHA and CHIP with all of the following organizations and entities: local public health authorities, hospitals, other CCOs, and if a federally recognized tribe has already developed or will develop their own CHA or CHIP, CCOs must invite the tribe to participate in the shared CHA and CHIP. These entities will be referred to as the collaborative CHA-CHIP partners. This collaboration shall be documented in the CHA and CHIP documents, inclusive of the CHIP progress reports. So the changes that we saw in section 1 were really to implement the policies that Sarah was reading, the policy number 8 specifically, and House Bill 2267 related to the shared community health assessment and community health improvement plan, and identifying those entities that have to share that piece. So local public health, hospitals, and tribes for the shared service area and other CCOs. So this collaborative partnership, we're calling it this because these are entities that have their own state or federal requirements related to a community health assessment and community health improvement plan, and that's why they get sort of really called out very strongly here, as well as to support policy 8. So questions or comments?
And by show of hands in the room first, seeing 1, 2. Can I do name only check-in on the phone, seated RAC members, just your name.
Aaron Jolly.
I heard Aaron Jolly and then Bill Buska. I think I heard another individual before Aaron.
Robin Traver.
Robin, thank you. All right, we're going to start in the room with Kristen Downey from Providence. Then I think we'll go down to, to Tom? Is that your hand? So Kristen Downey in the room, then Tom. Then in the following order, Robin Traver from Umpqua. And Aaron Jolly, thank you, from the Redmond Bend area. Then Bill Buska from IHN Samaritan. So Kristen.
Our comment is around the term shared. Although we have similar service areas with CCOs, we don't always have the same population or focus. So maybe a term more along the lines of like collaborate with, because we don't share documents. Although we collaborate maybe on needs assessments and developing a plan, we don't have a shared plan. So there might be similarities, but and some of us are on different timelines as well. So
thank you for the request. So we're noting that. Do you want to add anything?
So we will take that under advisement, Kristen. Thank you.
And the one thing that I will add is that OHA is planning for some guidance that will come out in October to better guide for the CCOs specifically to that shared piece.
All right. Tom Sinzek.
So this is related to what you just said, which is...
Microphone, please, Tom.
Tom Sensick, Healthcare for All Oregon. I think you just kind of led into my question, which is, it looks like this work is being done on behalf of the Oregon Health Authority as an sort of riding body, but somebody decided it's way better to have these things put out and done in communities and then report it back and let the OHA or the system will give them the money, and then the overall final accountability will be to the Oregon Health Authority. Am I understanding the reason for this work? I mean, is this work being done on behalf of the Oregon Health Authority or just based on the communities themselves?
When you say this work, you're saying the actual assessment and plan?
Yeah, right.
Okay. So it is meant to be community-driven?
Right. Okay. Yeah, and then it just stays there, or does the reporting comes back to the Oregon Health Authority?
So I think we're going to get in some sections later about what gets submitted to the Oregon Health Authority, but these are meant to be community-driven plans.
Thank you.
Okay. Thank you, Tom. We'll go to Robin Traver from Umpqua.
I'm actually going to save my question for a later section.
All righty. We will go to Erin Jolly, and I stated she was from the Ben Redmond area. My apologies. Erin Jolly from Washington County. Go ahead.
So later in part 7, which I know we'll talk about in a minute, but it says a shared chip or shared strategies, and so I think it's just unclear which it is because it doesn't have that same language in the beginning. So I just suggest that it's that it has the same language consistent, or it's one or the other, a shared chip or shared chip strategies.
Thank you. Thank you. We have that noted for consistency across.
All right. We'll recognize Bill Bushka from IHN Samaritan. Go ahead, Bill.
Thank you. This is up in 1, and this may be coming out in the guidance that was described that's coming out in October, but I would like some clarification on the second sentence where it says, to the extent the CCO shares all or part of the service area. So that concept was overlapping CCOs, but I'll just quickly give you our scenario for IHN CCO. Trillium from the south. We're completely county-based organization, but Trillium shares a couple zip codes up into 2 of our counties. And so it's just a really small geographic section. Are you saying that Trillium has to collaborate with us, or that we have to collaborate with Trillium? It's just a little confusing when it's such a small area that overlaps. But if that's coming out in the guidance, that would be excellent.
Thank you, Bill. And yes, the idea is to address that via the guidance. And thank you for the question.
And I think that was it for number 1, so we'll welcome you to continue with number 2.
Thank you. I'm actually going to walk through sections 2, 7, and 8. Beginning with section 2, which reads, in developing and maintaining a CHA, CCO shall, with the collaborative CHA-CHIP partners, meaningfully and systematically engage representatives of local and tribal governments, community partners and stakeholders, and critical populations to assess the community health needs of the contractor service area. The rule then provides a list of specific organization types and groups that must be meaningfully and systematically engaged. It's not an exhaustive list. Section 7 then reads, using the findings documented in their CHAs, including any health disparities data and other reliable data, CCOs must draft a CHIP, which shall serve as a strategic plan for developing a population health and healthcare system plan to serve the communities within the CCO service areas. Any collaborative CHA and CHIP partners from the shared CHA must collaborate in the development of a shared CHIP or shared CHIP priorities and strategies. The CCO's CACs are responsible for adopting CHIPs. And then finally, section 8 reads, in developing a CHIP, the CCO shall, with the collaborative CHA-CHIP partners, meaningfully and systematically engage representatives of local and tribal governments, community partners and stakeholders, and critical populations Again, the rule then includes a list of those specific organization types and groups, which mirrors the groups to be engaged through the community health assessment process. So these changes highlight that the government's partners and stakeholders now must be meaningfully engaged in the CHA and CHIP process. Also of note are the additions of tribes, social determinants of health and equity partners, and traditional health workers, and culturally specific organizations. So I'll stop for questions.
Sarah, if I can also point out that the inclusion of the local public health authorities and the hospitals was pursuant to House Bill 2267. I think we mentioned it earlier, but we certainly want to make that clear that that is under legislative direction for us to add those. So happy to open at this time. Can we see by show of hands in the room first? All right. I'm going to go Glenn. Hands still up, please. I'm sorry. Glenn, Lisa, Christine, and then Tom. And may I just get a check-in on the phone, name only, of individuals wishing to speak? Just by name on the phone.
Rachel.
Rachel? Okay, I've captured her. Thank you, Rachel. Any individuals on the phone, just by name only at this time? All right, we will go Glenn, Lisa, Christine, and Rachel. Please all use the microphone. Thank you. And state the name of the organization you're with.
Both red and green are on.
That's good.
That's good.
Oh, what is it?
This is Glenn Kirsten. The word critical bothers me a little bit because I don't have the document.
Glenn, sit tight 1 sec, sorry.
I don't have the word document in front of me, but the word critical seems to me could be interpreted differently. And so is there another word, underserved or something? Critical by itself depends on the eye of the beholder, whether it's critical or not. So I worry about that word.
Great, thank you.
All right, Lisa.
Lisa Rose, Disability Rights Oregon. I'm not sure, so in 2 and then again in 8, I'm not sure if local law enforcement or the criminal justice system would be represented in the county and city government or in the local mental health. I know that some counties' mental health is the county provider in the jails, but we know that jails and the sheriff's department are coming into contact with lots of individuals with mental health conditions as well as physical health conditions, and would be very important to be at those tables and very important stakeholders. So I'd just like to recommend that be added.
Thank you. And we will go to Christine.
Christine Bernstein, Health Share of Oregon. In terms of partner engagement in subsections 2 and 8, it doesn't explicitly call out OHP members. That could be implied as representatives from populations who are experiencing health and healthcare disparities, but we might want to consider calling out OHP members specifically.
Great, thanks.
Thank you. And Rachel Banks, I apologize, couldn't see you down there at the end of the table. Go ahead, get your microphone.
So I had a question in terms of the definition of population health, and it might be kind of ripping off what you were sharing, Christine, but what's the definition of population health? And I think particularly thinking about it coming as a local public health authority, we have a definition of population health that is beyond the OHP members and includes the entire population of the region or jurisdiction. Whereas I've seen in some conversations, the population could be defined as the CCO's population of service.
Thank you. The intent here is that population health means all members or all people residing within the service area, which would be OHP members and non-OHP members. And we can consider whether there's a clarification we can make.
And thank you, Rachel. Can I do a check-in name only on the phone? Individuals wishing to speak to this particular subset of the rules numbers 2, 7, and 8. Can I?
Robin Traver.
All right, Robin, sit tight 1 moment. Anyone else on the phone? Can I see by show of hands? And Tom, I may have missed you. If so, my apologies. Anyone else in the room? We will start with Tom Sinzek and then Robin Traver.
Tom Sinzek, Healthcare for All Oregon, in number 2 in the introduction. I usually go for more restrictive, but there's words in the end. This is the following must be engaged, and then without limitation. I don't know. This is, I put it on here, this is a monumental task to pull all and every and no limits, cautionary tale in that one. So throughout both this one in 2 and 7 and 8, and I'm going to have a, okay, we're not talking 6 yet, right? Okay. Okay, so there's an alignment in language here with Senate Bill 770, which is now Chapter 629, 2019, in terms of the people that will be on the task force and the advisory committee. And so you might look at those lists, and let's not duplicate work or who's all has to be in multiple places at the same time. It could be that this list feeds into who's on that task force or that list of people. So I would suggest, in particular, in number 7, because we're talking about, it's mentioned a healthcare system plan. Well, SB 770 calls for the creation of the Healthcare for All Oregon plan. So I would say, after in plan, in the word in alignment with the intent of SB 770, Chapter 629 of 2019. And it's, I would say, in alignment with the purposes, principles, and values of Senate Bill 770, Chapter 629 of 2019. And that's all my comments. Thank you.
Thanks.
Thank you, Tom. Robin Traver from Umpqua.
Yeah, under number 7, we want to ensure that we still have a strong voice of our PAC in the CHA and the CHIP. Is it possible for having, a shared CHA and CHIP and then an appendix specific to the CAC?
Thank you for the question. I'm not sure I'm completely understanding the question. I can say that we will be providing additional guidance and instructions to CCOs in October.
Robin, do you want to expand context what that appendix might look like?
No, I'll follow up with the director that provided this comment, and we can submit it in writing if she has additional questions.
All right, thank you. Last call in the room for numbers 2, 7, and 8 before we move along by show of hands. Last call on the phone, name only. All right, Sarah and Anona, please continue.
Okay, so I'm going to read sections 3 and 9 right now together. I'm not going to, and just note that these have some pretty long lists. I'm not going to read all of the lists, but I'll kind of point out some key highlights. And these sections include the required elements or resources that guide the CHA-CHIP development process. So section 3, the CHA must include or identify and analyze at a minimum all of the following. That's where we have that big exhaustive list. I'm not going to read through the whole thing. And then section 9, a CHIP adopted by a CAC shall describe the health priority goals and strategies that will govern the activities and services the CCO will implement in order to address the population health needs and resources of the community. And again, we have a big list here. So a couple things I want to highlight that were changes in here. So first, one of the goals that changes overarching across both sections 3 and 9 was to clearly outline what the community health assessment the CHA must assess and how the findings from that CHA are addressed by the community health improvement plan, the CHIP. Changes of note specific to the CHA includes clearer language on including demographics and health indicators, along with the remaining focus on health disparities. So that is from the prior language already. There's also the addition of the social determinants of health and equity indicators, assets and resources that can be utilized to improve community health, as well as programs that promote the health and treatment of children and adolescents. Changes of note for the CHIP include clarity on the required elements for the CHIP, which include the goals, strategies, metrics or indicators to monitor progress, and addressing the needs of children and adolescents. So those are the highlights. And now I want to pause and take questions and comments.
And by show of hands in the room first. I'm seeing 2 hands in the room, 3 hands in the room. May I hear name only on the phone, RAC members that wish to speak to this?
Aaron Jolly.
And anyone else on the phone?
Sandy Sampson.
And anyone else? All right, we are actually going to begin on the phone with Aaron and Sandy, then we will go back to the room here. Aaron, go ahead.
This is for Section 9, and I would suggest that there be more clear language or a recommendation that CHIPs have a connection with CCO strategic plans or other CCO strategies, so that the CHIP work doesn't kind of become siloed from other CCO strategies, and a clear connection to social determinants of health and health equity strategies and investments.
Thank you, we have that request noted.
All right, appreciate that. Sandy, go ahead.
Yeah, and I might be looking at the wrong document, but in 9 at one time there was developing and implementing best practice of culturally and linguistically appropriate care and service delivery. Is that still inclusive or not?
So that is not in Section 9, but we can go back and look. You're saying that it was in the prior version of rules, and Sarah's pulling up the red line.
It was in the original first draft, and it was when CCO 2.0 went to tribal organizations with Pat Allen. There were some things that were appropriate for it being developed in, whether it's a CHA or a CHIP.
Sarah and I will go back and look at the prior version, and we will have to get back to the RAC with the answer to that one.
And Sandy, it's possible that that may have been another piece of documentation or something else that was provided during that meeting. I don't know off the top of my head what was shared, so we're reluctant, but we can certainly follow up and look at the version control there. Let me recognize Kristen Downey from Providence.
Starting on Section 3, little g, some of the stuff, since this falls under a category that says at a minimum, in this section, when you're asking CCOs to evaluate the effectiveness of some of the community programs, is this something that's like from statute that they're required to do? Like,
It's a good question. So specifically, a lot of what you're saying for children, adolescent health came, and I really want to get back to confirm that I have the right numbers here, but I believe it was Senate Bill 902, and now statute 414.629. I'm not positive. I need to go back and look. But I believe that most of the language you're seeing anywhere in this rule comes straight out of that legislation and that statute. But I'll go back and verify.
so I think, from our understanding, it was more of a, not the accountability for a CCO to identify those programs and evaluate those programs, but more of an intent to collaborate with those programs, and this just doesn't seem to read with that, how we understand it.
I'll go back and verify. I'm fairly sure, but I will verify that this language may directly mirror what's in statute, so we'll look and make sure that we have consistency so that we're following the legislative intent there.
The next one then on Section 9. There's been a lot of back and forth over the last year or so about really trying to reinforce the fact that the community health needs assessments are informing the plans. And so continually throughout this rule, I think it's problematic that there's these kind of long lists that fall after the without limitation that I think are maybe good examples for things to consider, but may do better in a guidance document than in rule. And you could, end these sentences without those lists.
All right, and still in the room, Tom Sinzek from Healthcare All Oregon. Do I see anyone else by show of hands wishing to engage here? So after Tom, we'll go to Marion Blankenship from Pacific Source, and I'm just looking down the table to see if there are any other hands. All right, Tom and then Marion.
Tom Sinzek, Healthcare for All Oregon. If I'm reading this properly, number 3 calls for identifying, of course, and analyzing. And I look at some of this stuff, especially on E, 4 key domains, and the idea of study and study and study, rather than spend money on implementing, collaborating, working with, and in all of my years in school-based clinics and working in the jail, things that we did to, just made sense to bring a community health nurse into the jail to talk to the community, to talk to the drug-affected women that were entering the jail system. And not to study it first, but just to go ahead and start bringing them in. And so I want to just say we shouldn't overemphasize the word analyze, because in the school-based world, a lot of the stuff about ER visits and pregnancy, mental health, all this stuff's already documented out there. And so maybe you can identify it, but more emphasis on implementation. So that was, E was an important part. And then particularly, let's see, which part are we? D under F, 3DF. This is important, the systems of seamless continuum of care, all right? And the CCOs in themselves in our healthcare system is a seam-filled system. And we went through the other rules that were in the previous committees. There's seams everywhere. And so the essential element of SB 770 is, defines this thing about seamless systems. So again, I would encourage you all to look at SB 770, find the alignments, and make them happen. So especially, it's the groups, it's this list of things, it's all written in another bill somewhere now, so thank you. Or another part of the Oregon law. Thank you.
Thank you for your comment.
Thank you, Tom. We'll go to Marion from Pacific Source.
Great, thank you. Comment in regard to 3, small f, D, and E. Just a suggestion, if possible, to clarify further the terms in D and E, so systems of seamless continuum of care and systems or programs of collaborative governance of community benefit, just quite vague. So if it's possible to clarify, that would be great. And then in regard to subsection 9, so 9 small d, A through D, the language around engaging with school nurses, school mental health providers, etc., which we entirely support. And I sat on the task force with Tom, and we know it's important. The one thing that I think will be fairly essential is clarity around roles between school providers and those school systems and CCOs, and also a clear articulation of the scope. Thanks.
Thank you.
All right, I'd like to do a check-in on the phone. Again, name only. Anyone wishing to speak to this particular set before we move on?
Kimberly Coop.
And your name again, I'm sorry?
Kimberly Coop with the Route Search for Oregon Foundation.
And anyone else besides Kimberly? All right, Kimberly, the floor is yours.
Thank you. I was wondering, because it sounded like earlier, and maybe this is just because I was on the phone and it was a little hard to hear, but it sounded like we were talking about policy number 8 that was in the recommended policies that requires that CHPs address at least 2 state health improvement plan priorities based on local needs. And I didn't see that anywhere in the rules, and I was just wondering if that is in the draft rule somewhere.
Thank you. So it's not in the draft rule, it is in contract for CCOs.
Great, thank you so much.
And anyone else? Last call. All right, we welcome you to continue.
Oh, I got.
Oh, Tom.
Sorry, this school stuff is so dear to my heart.
Mike, please.
Tom, the microphone, please.
Yeah, sorry.
Tom Sensick, Healthcare for Oregon. So under, I think it was under 9, right? Yeah, 9, D, C, goes like this. Take into consideration whether integration of school-based clinics with the larger system would further advance the goals of the plan. I'm kind of laughing at that. Of course they would. We don't need to take into consideration. We need to say something, must understand that the integration of school-based health centers with the larger system will further advance the goals of this plan. It's not a question.
Thank you for the recommended change.
Yeah, thank you.
All right, appreciate that. And we will move on with numbers 4, 5, 6, and 11. And just, do you wish to plow through, were there any hands down towards the end? I'm sorry, Jeremiah, did I miss you?
Sorry.
For section 4?
Numbers 4, 5, 6, and 11. You may have, I'm not sure if you had heard, but they were going to do this in a bit of
Yeah, I did hear.
Okay.
I was wondering, are we talking about section 4 right now? Okay.
We're right now.
All right. You're good.
Go ahead. All right.
All right, I am doing 4 now. So section 4. So as it reads, the CCOs, CACs, the Community Advisory Councils, shall oversee with the collaborative child chat partners the development of the shared CHA. And really, the change here is the addition of with collaborative partners. So questions or comments?
Individuals in the room or on the phone, by a show of hands in the room. Names on the phone. Anyone on the phone? All right, Tom, go ahead with the microphone, please.
Tom Sensick, Healthcare for All Oregon. I just have a few comments. Reversing the musts. Under number 5, saying may, I think it must be a must collaborate. I don't know if that's optional, but looks like the word should be must collaborate.
Are you on 5?
5.
We are almost there.
Okay.
But we have your note. No.
Okay, and I'm done with 5, so thanks.
Okay.
All right, go
I'm
ahead.
going to jump right into section 5 then. So, Tom, I have your note about changing the may to must. All right, CCOs and their CACs must develop meaningful baseline data on health disparities identified through the CHA process. CCOs and their CACs may collaborate with the authority in developing this data, which includes health disparities defined by race, ethnicity, language, health literacy, age, disability, gender identity, sexual orientation, behavioral health status, geography, living settings, or other factors. This data will be used to identify and prioritize health disparities in the development of the CHIPs. So you actually hit on, Tom, the one change was changing the must to a may. It used to say must collaborate with the OHA Office of Equity and Inclusion. So it was that actually was changed to a may. But we have your recommendation to switch it back.
May I ask a question related to that? Doesn't OHA have data and information that may be really essential to the work and avoid duplication? That's just the comment, like, looks like potential replication of work if there's not essential collaboration at some level.
It's a good question. I will just say there is guidance already available to CCOs related specifically to data, and yes, there's a multitude of OHA data, so I agree. This is something that we have guidance on for CCOs.
So before we go to Jeremiah, can I see additional show of hands in the room of anyone wishing to speak to this? May I hear name only of any individuals on the phone that wish to speak to this? All right, Jeremiah, go ahead.
All right, Jeremiah Rigsby with Care Oregon. For section 5, I think, and I don't want to boil the ocean here, as I know this language has probably existed. We've struggled getting the right data on our population. I know we all know we're missing a lot of race and ethnicity data. So I'm wondering, in the first line, CCOs and their CACs must develop meaningful baseline data. You have a good idea what meaningful baseline data means?
So this is one where it sounds like you're recommending some clarity on actually defining that within the rule language.
I would recommend clarity and grace, considering how much data is missing. Yeah.
Thank you.
All right, we are going to go to Helen Blankenship. Clarity and grace may be the 2 nicest words I've heard in the last 2 weeks. With that said, Marion, please.
Great, thank you. Mostly want to echo Jeremiah's comments and also just, again, remind us that in rural communities, this data can be even more difficult to collect.
Thank you.
Thank you. And apologies, your name tent is turned. Emily from
Tides of Change and the Oregon Coalition Against Domestic and Sexual Violence. And number 5, living setting seems kind of vague, and I don't know if you're talking about environmental factors and like EPA living settings, or living settings in terms of experiences of violence, given the connections between intimate partner violence, community violence, and other mass experiences of violence. And I think that should be called out. That's my recommendation.
Thank you.
And additional individuals in the room by show of hand or by name on the phone? All right. Go ahead.
All right, so section 6. So CCOs shall develop, review, and update its CHA at least every 5 years or more often, if so requested by the authority. The change here is the at the request of the authority more often, and that's the only change there.
And by show of hands in the room or name only on the phone? I see 2 hands in the room. Before we start, any name only on the phone?
This is Bill.
All right, Bill, let's start with you on the phone. Anyone else on the phone? All right, after Bill, we'll go to Marion and then Tom. Go ahead, Bill.
Okay, thanks. So this may be a obvious question, but can you give some idea of why OHA would request it be done? Would that be for all CCOs or a single CCO? It's just very open-ended and in parentheses, just not, seems odd. I don't know why OHA would do that.
Thank you, Bill. A situation where we would do this. So the one thing that comes to mind, Bill, would be a situation if a community health assessment was completed that really just did not fulfill any requirements shown in contract, statute, OAR, that the authority could request one sooner because it clearly didn't fulfill the obligation.
And any follow-up, Bill?
So that would be on an individual by basis for a CCO, or just for OHA to tell all CCOs, oh, you guys need to do one now. It just seems to provide a lot of flexibility and grace for OHA in this one.
As the language stands, it could allow for either, but we can consider some clarity based on, sounds like a recommendation for requested clarity.
All right, we will recognize Marion Blankenship from Pacific Source.
Who is echoing again, so I'm echoing Bill's comment. I think that our concern obviously is there is a significant administrative and financial lift in undertaking a CHA on a chip. So it would be helpful to have some sort of criteria or guidance around what would trigger that.
Thank you.
And Tom, go ahead.
Tom Sensick, Healthcare for All Oregon. I thought about, boy, this is a heavy lift, administratively expensive to keep doing an update, but we live in rapidly changing times. I've like the last 3 years, I just stay in the city of Portland, and the homeless issue or the drug addiction problems, these issues that people are facing, and if you look at a 5-year time frame, how responsive is that going to be to what a community needs? I'm concerned that there has to be a mechanism of checking in, like a blood pressure every week, or a peak flow meter, or spirometry often enough to make sure that you're being effective in what you're doing. And 5 years is not a framework into which to be effective. I wrote 3 years in here, but I'm not even sure that makes sense. So it doesn't look like it's going to do what it needs to do. It might be just a waste of money.
Thank you.
All right, and Kristen Downey from Providence. Will there be anyone else that wishes to speak, either in the room or on the phone, to number 6? All right, Kristen, go ahead.
So I just wanted to use this as an opportunity to highlight one of my first comments about the word shared. So as hospitals, our hospitals are required to do these every 3 years. And so if we're on different timelines, different cycles, then although we can contribute to the conversation, share information, we're not always going to be able to do it at the same time as required in that section 1.
Thank you.
All right, thank you for that. Last call on number 6. All right, go ahead, Sarah and Anona.
So, section 11, and just as a note to everyone, any sections that we have not explicitly read out, it's because those sections did not have substantive changes. All right, so section 11. Or did I skip it?
No.
All right, so So in addition, CACs shall annually publish a CHIP progress report that evaluates and describes progress towards advancing CHIP goals and strategies, addressing health disparities, and improving health equity. Progress reports will be submitted in the manner and form prescribed by OHA. So really what was clarified here was sort of high-level scope, what does the progress report need to include, and that the manner and form prescribed by OHA, essentially we have a questionnaire that is supplement to the full progress report. And so we are able to produce that for CCOs.
And any individuals on the phone by name only that wish to speak to number 11? Any individuals in the room by show of hand? And I'm seeing one hand. Rachel from Multnomah County, go ahead.
So my comment is in regard to the word addressing health disparities, and would request that it was reducing health disparities, so that this was not just people talking about what process or what strategies they had done, but they were really talking about, were clear about that the goal is to reduce health disparities.
Thank you for the recommendation.
Thank you. Did I see another hand over here? Kristen, go ahead, sorry.
With Health Share of Oregon. Just a question about how, if this is reporting on the CHIP, health disparities and health equity, how it relates to the required health equity plan, and if there will be duplicative reporting with different timelines and similar information. Clarity on that would be helpful.
And we will get back to you with clarity on that. They're not a one-to-one, you're right, but there is potential for overlap.
Thank you. Any additional comments, individuals in the room or on the phone? Phone, first name only.
Maureen.
All right, Laureen, just one moment. Anyone else on the phone wishing to speak to number 11?
Sandy Sampson.
All right, anyone else? All right, let's start with Laureen and then we'll go to Sandy. Laureen, go ahead.
Just a quick question: if there's going to be any standardized format that will be used for this reporting, so that the CCOs across the board can be reporting the same information in the same format and make it usable to evaluate the data.
Thank you. Thank you for the question. There is not currently a standard format for the progress report, although there is as I said earlier, the supplemental questionnaire that each CCO is required to complete and submit to OHA along with the progress report.
Okay, I just encourage us to develop a standardized approach to the reporting for the CCOs. It will make it easier for them and much easier for OHA or anyone else that's trying to evaluate.
Thank you.
Thank you for the recommendation, Laureen, sorry. And Sandy from Yellowhawk, go ahead.
So in the draft SDOH, the Social Determinants of Health, there's a part in there that says the CCO's most recent community health improvement plan, that is shared plan with collaborative partners, that as defined in this section, the 3730, including local public health authorities and local hospitals. If the CCO has not yet developed a shared plan, the CCO shall align its priorities with those identified in the CHIP's development by other stakeholders in the service area, such as local public health authorities, hospitals, etc. So are you guys collaborating those two together so that they're mixing or matching what you've drafted in one area to the other area?
Can you repeat the question? I'm not sure I'm following you completely when you say, are we collaborating from one area to another and combining them?
So portions of the spending of the social determinants of health draft regulation, is it coinciding with what you've developed in this portion of your community health assessment and community health improvement plan, so that we're making sure both areas are looked at? So if you read the current one, 410, 41, 37, 35.
And Sandy, if I can ask, what section are you speaking of in 3735 specifically?
Section, just a minute, now I lost it. So it's It's just the draft one that we did on the August 1st.
Sure.
So it's A of, what number? So it doesn't really show where it's at, but it's in that section. It's the new one. It's down towards the middle of the page. So I'm just curious that they coincide with what you're looking at in one area, and it's inclusive in the chip.
And I'm reading the language right now, hold on.
Anyway, but if you could look at those two and make sure that they coincide with each other of what you're asking.
The language we did collaborate to make sure language mirrors each other so we're not conflicting from one rule to another, if that's the question.
Yes, it is.
All right, thank you for that. Any additional comment, feedback in the room or on the phone? See one hand in the room. Any additional hands in the room? Anyone else on the phone by name only? All right, we're going to go to Tom. I think this will be last call.
Tom Sensick, Healthcare for All again. I have a question. If people are on open cards, do they fall not under any CCO? Right? If they have an open medical card, do they belong to anybody?
So if fee-for-service, open card is synonymous with the term fee-for-service.
Right.
So those are individuals that go to providers that agree to contract with Oregon Health Authority, Oregon Health Plan under federal any willing provider statutes, and that reimbursement comes directly from the state of Oregon, not through a coordinated care organization. It's not a capitated arrangement.
Okay, so they're separate. So as we go forward, just thinking of a picture under this other part of 770, which is a Medicaid buy-in, and if they come under a fee-for-service, depending on how that all gets played out or belong to a CCO, I guess that's yet to be determined. Thank you.
Sure. All right, additional questions or comments on the phone? If not, I would invite Sarah or Sarah or Anona to offer any final words or thoughts. And we have
a question.
Another question.
Is provision 10 still in there?
Yes, Emily. No, we did not read every piece if there wasn't any substantive change to that piece. So the question was about whether section 10 is still in there. Or are you looking at the old version? Prior rules.
I don't know. Okay. It's the one that's specific to OHP member reporting as opposed to, I can submit something and write the question and write.
Thank you.
All right, any additional comments on the phone? All right, as a reminder, all seated RAC individuals have the right and opportunity, which we encourage you to do, to follow up with us in writing. Comments, close of business next Thursday, 5 o'clock. Wait, before we adjourn, we do have one individual that has signed up for public comment today. It is Megan Dorton from the Legal Aid Society. Megan will be afforded the full 10 minutes if she wants to. That is her prerogative. Megan, are you still with us?
I am. Thank you very much.
Sure. Go ahead.
Okay, so I am providing commentary here on health-related services rule 410-141-3845. So at the core of our state's Medicaid transformation was the recognition that the essential ingredients for health are not often found in a hospital or provider's office. Our waiver gives CCOs the latitude to pay for things that Medicaid would not typically pay for, which address the social determinants of health. The flexible services are a cornerstone of our state's ability to meet the health needs for our entire community. And we should be expecting and employing strategies for the creative use of flexible services. These are critical benefits that have life-saving effects on some of our most vulnerable people, including and especially domestic violence survivors,
Flexible services provide immediate necessary assistance for survivors to leave dangerous situations and to stabilize their health and their safety, preventing more trauma and physical harm, especially to children. So in service of that, of those policy goals and requirements, Legal Aid Services of Oregon would suggest the following that emphasize the testimony or the commentary that Oregon Law Center has already given. First, that this rule include language to ensure and encourage the use of flexible services for individuals by CCOs. That this rule have a requirement that CCOs must inform network providers and members of the availability of flexible services and the process of how to request them. We also request and recommend that this rule reincorporate the former language captured in the current subsection 4 of the current rule that is consistent with its federal regulatory counterparts that provides specific illustrations of the use of flexible services, including flexible service uses toward housing, toward providing intensive case management that otherwise wouldn't be covered, for providing medical equipment that is not otherwise covered to vulnerable folks. We also request that there be public and mandatory detailed reporting of how flexible services are being used by CCOs that address the lack of evidence that we're seeing of how these funds are being utilized. And then finally, we emphasize that due process requires that that members be given more than just this grievance, that there needs to be a panoply of due process requirements that are consistent with full Medicaid due process requirements to allow folks to appeal adverse determinations regarding flexible services. Thank you.
Thank you. You spoke specifically. We do appreciate all of that. To HRS, did you wish to offer any commentary or public comment on the CHIP rule, community health improvement plans, and community health assessments? You do have 6 minutes remaining. It is your right to use that if you choose to.
I couldn't tell if this was Dirk. This is Megan Dorton from Legal Aid. I have no further commentary.
Okay, yes.
Your first part cut out.
All right, Megan, we appreciate your comments today. Thank you. Thank everyone that has participated in the room on the phone. We appreciate. Again, friendly reminder, close of business next Thursday, 5 p.m. In your subject line, please note your organization.
Could you please state the email address that we should use to send this to?
Sure.
CCO 2.0 CCO 2.0 rulemaking at dhsoha.state.or.us.
And any confusion there, it is one on the website on our RAC page, Rules Advisory page, and the same email address that folks did RSVP. So again, we thank you for your participation today.